So I'll be brave if you're brave. I'll be brave, but only if you're brave.
Good afternoon. Welcome to those of you who are able to join us today during our special edition Lung Cancer Living Room. I'm Danielle Hicks, Chief Patient Officer here at GoTo for Lung Cancer. For those of you who aren't familiar with our Living Room program, it's a support and education series created specifically with patients and caregivers in mind, with the goal of bringing to you live and in real time educational talks from key opinion leaders in the lung cancer community and in a format and a language that is easy to understand. Today, our guest speaker is Dr. Stephen Liu, Associate Professor of Medicine, Director of Thoracic Oncology, Director of Developmental Therapeutics, Lombardi Comprehensive Cancer Center at Georgetown University. Dr. Liu will be talking about new horizons in lung cancer research, discussing what is shaping and driving earlier detection, new treatments, and access to care strategies. We hope that you'll find hope in the information provided. Please enjoy the show.
Thank you for being here today. Thank you for letting me be here with you and for all the work that you're doing. My name is Stephen Liu. I'm from right up the road at Georgetown University. These are my disclosures here. And what we've heard about, what we've been talking about at this summit really is progress. And we've made a lot of progress. I think this is part of what progress looks like. These are new FDA-approved drugs for lung cancer across time. What you can see is that we were used to a few drugs being approved every decade. And in the past 15 years, we have had an explosion of new transformative medicines available to our patients with the development of targeted therapies, with the integration of immunotherapy in patients. We have come a long way. And so how do we get here? How do we see so much progress in a short period of time in lung cancer? You know, we've heard about other cancers, oncology in general. I can tell you lung cancer is leading the way. Right? And so how do we do that? Well, we started by changing the way we think about lung cancer. In the 80s, 90s, we were searching for this silver bullet, a treatment that would work for everyone with cancer, eradicate the disease, sort of an easy-on, one-size-fits-all solution. That's just not what lung cancer is. And our biggest breakthroughs came from going smaller, from understanding that we need to study this disease. We need to look at the biology, uncover its vulnerabilities, and exploit those. And our biggest breakthroughs came from getting smaller. We start with the patient. It has to start with the patient. We take those vulnerabilities or understanding that biology, go into the lab and design medicines that will work against this cancer. Take it to the patient, and if it doesn't work, or if it works and stops working, understand why. And then take that information back to the lab and design better drugs from the patient to the lab, back to the patient, back to the lab. This is how we make progress. What we have to do is rethink how we deliver these medicines, rethink what we're capable of. Work with the FDA for faster approvals, accelerated approvals, pragmatic trial design. Develop new, innovative trials. We go from simple phase 1, phase 2, phase 3 studies to basket studies, to umbrella trials, OCTOPUS studies, platform trials with Bayesian designs, getting better at delivering medicines to our patients. This is how we go forward, with the end result being getting our drugs to the patients faster. And so what used to take a decade now can be done in a year, because speed is essential. Progress is new drugs. Drugs that are approved quicker, that get into the hands of our patients faster. Progress is survival gains. In the fall of 2022, the American Lung Association mentioned that we saw a vast improvement in 5-year survival for lung cancer, a 21% gain from 2014 to 2018. That's a huge gain. We're used to incremental, a few percentage points. We're seeing leaps in lung cancer. And what's more important is the possibility of long-term survival for some patients, potentially cure for some patients. Earlier detection, lung screening saves lives, getting those cancers at an earlier stage and increasing awareness. And as we always say, anyone with lungs can get lung cancer, making this something that's more comfortable to talk about so we can tackle this problem head on. And we're making a lot of progress from studies like this. This was a large meta-analysis published in our flagship professional journal, Journal of Clinical Oncology, a meta-analysis showing that chemotherapy improved survival compared to best supportive care alone. We've come a long way from this. This showed that chemotherapy did something, that treating lung cancer led to better outcomes. The benefit was modest, a 9% improvement in one-year survival from 20% to 29%. This was what progress used to look like. I want to highlight one thing here. Look at the date. The date here is October 2008. That was not that long ago. I had just started my fellowship, which means if you're an oncologist in this country and you did your training before me, you were still asking the question, is it worth treating lung cancer at all? Look how far we've come. This is where the nihilism comes from, because previously we didn't know we had active drugs. This is why there's this resistance to treating lung cancer, because this is all relatively recent. And we've come a long way. It is our job now to tell the world that there's a lot happened in the past 15 years. It started really with classification. Now, oncology is not an old discipline, but in the early days of oncology, it was readily apparent that lung cancer was different from breast cancer, it was different from stomach cancer, from prostate cancer, different local therapies, different surgeries which were available at the time, early responses to different types of treatment. We didn't have a lot of drugs back then, but nitrogen mustards versus aminopterin, we would treat these cancers a little differently. They had different complications. That was easy. But our pathologists began to tell us that under the microscope, these cancers looked a little different. Some were very small, we called those small cells. We had adenocarcinoma, squamous carcinoma, some differences under the microscope. And so we began to classify these cancers differently, to give them names. Now, why do we do that? Why do we classify things? Why do we organize things? This isn't like organizing a record collection. This is different in medicine. We do it in medicine if it matters, if it changes our treatment, if it's worth our time. And so early on, we noticed these differences, but it was when we started seeing that these cancers behaved differently, they responded differently to treatment, that we really dove into classification. Back in the 1960s, the VA Lung Group, we looked at early chemotherapy drugs. Didn't have a lot of things to choose from, but some of the investigators there noticed that small cell lung cancer seemed to respond better to cyclophosphamide. Non-small cell cancers responded better to nitrogen mustards. And so from that moment, if you were treating lung cancer, you needed to know the difference, because then that would change your treatment. It mattered because it changed your treatment. Newer chemotherapy agents, adenocarcinoma versus squamous cancer, we use different chemotherapies based on efficacy, based on safety. We classify them on adeno or squamous because it mattered, because it changed the treatment, because those were different types of cancers. In 2023, we know that if we subject a tumor to DNA and RNA-based next-gen sequencing, we can reveal molecular targets. We can understand the molecular drivers of those cancers by identifying specific DNA mutations or chromosomal rearrangements. We can uncover specific vulnerabilities, and we now have drugs that will match these changes. And so now, identifying these differences, doing this type of testing matters, because it changes treatment, because these are different cancers. And this is how we made progress in lung cancer, by understanding it's not one disease. It's a family of related diseases that starts in the lung, but each of these deserves to be treated a little differently. And the field of targeted therapy has changed lung cancer, and other cancers are now starting to catch up. We're seeing this spill over to all forms of oncology. At the same time, we're seeing the development of immunotherapy. So this is a list of targeted therapies that are now FDA approved. It's a long list. The font gets smaller and smaller each year, and so it's already a little hard to see in the back, and we're going to keep getting it smaller and smaller. These drugs are potentially transformational. They're allowing patients to live their normal lives. And if we look at how quickly our drugs are being approved, it's a far cry from previous drug approval. This is ALK, anaplastic lymphoma kinase, occurs in about 5% of lung cancers. The first case of ALK in lung cancer was in 2007. 2 years later, we found a drug that worked. 2 years after that, we had a drug approved. This process that used to take decades can now be measured in terms of just a few years. And these are transformative drugs. If we look at one agent in particular, alectinib, for example, not even the newest agent, our response rate here, 83%. Let me give you reference for that. Chemotherapy, which was our historic standard for decades for lung cancer, the chance of response to chemotherapy is about 15 to 25%. We want it to be higher. It's actually pretty low. And so when we give chemotherapy, we hope that it shrinks the cancer. We don't always expect it to. Whereas here, if we see someone with an advanced cancer, we find an ALK fusion, I have the confidence to know that if I give this treatment, 83% of the time we're going to see a significant reduction. These are well-tolerated drugs. They work very quickly, and this is the type of confidence that we want to have in oncology, where we're not guessing, we're not hoping, where we know that this is going to work, and it works for a long time. The median progression-free survival with this drug, not even the newest drug, is almost 3 years. That means we started treatment, we expect that to work for years, whereas chemotherapy in the past, we were thinking weeks to months. Now the first treatment can work for many years, and for some people, they won't need another treatment. Average survival, we can't even report it for many of these studies because we haven't hit the average. 62% of patients still alive at 5 years. In 2008, the median survival for lung cancer was 1 year. Now we have a significant improvement in 5-year survival. This is a waterfall plot. Each of these bars, these vertical bars, represents one patient on this study. And if the bar is pointing down, that means the cancer got smaller. What we can see is that most patients had a significant reduction in their cancer. And when targeted therapy first came along, we would see these and be wowed. We would pat ourselves on the back. These are so impressive. Now, when I look at this study, I immediately look to the left. I don't say, look how well this worked. We expect that with targeted therapy. These are designed drugs. We expect these to work. When I look at this graph, look what happened on the left. Why didn't this work for everybody? And that's how we make our drugs better. And for this trial example, we know that 2 of those people on the way left never actually got the drug, included in the study because they were part of the trial, never received the drug. That explains why it didn't work there. But we want to know, why doesn't this work for everyone? Because that is our bar. That's our expectation. This is one of my patients that came in very sick. One of the first patients I treated with alectinib had cancer spread to the liver, the bones, the lung, the brain. We see large tumors in the liver. We actually had a lesion in the eye and affecting vision on that right eye within days of taking alectinib. All symptoms gone, the first scan, all of that tumor relieved. This is about 5 years ago. If we hadn't tested, we would have treated her the wrong way, and we would not have had as good an outcome. Immunotherapy has also changed things. This is all happening in parallel. Now, we all have heard immunotherapy. It's seized the narrative. We see it in the lay press. We see it direct-to-consumer advertising and commercials. We see a lot of excitement about immunotherapy. What I can tell you, it is absolutely justified. All right, these are transformative medicines. They're not perfect for everyone, but these have really changed lung cancer in very important ways. Typically, these are IV medicines, antibodies, that target certain molecules on immune cells in cancers. We first saw this really studied in lung cancer, presented in 2012 by Dr. Julie Bramer at Johns Hopkins. This drug, BMS 936558, which we now know as nivolumab, was presented. What she showed was the chance of response was kind of low, 18%. We actually thought pretty good at the time, but an 18% chance of response. What really caught everyone's attention was the durability, because for some people, this was lasting for years. It's the first time that we've seen spider plots even, because we didn't have to go out so far before. We weren't used to this. This was a scale that we were not expecting. We thought it was a mistake. We thought we were hearing it wrong. And this was so unexpected because immunotherapy was not supposed to work in lung cancer. This was so unexpected that when this was presented at ASCO, it wasn't at the presidential symposium. It wasn't at the plenary session. It wasn't even in one of the main lung sessions. It was in a small clinical symposium, way at the end of the hall, past the break room, past the fellows room, past the exhibitors room, the far end, where there weren't any food vendors, plenty of seats, and we saw unbelievable results. We weren't expecting it, but it caught our attention because this was transformative. All right? This was a small group of patients, but from that, within a few years, immunotherapy replaced docetaxel chemotherapy as our preferred second-line treatment, better survival, better safety, better tolerability, and a few years after that, it became our preferred frontline treatment. We now have many ways to deliver immunotherapy. The first one, Keynote 024, looked at pembrolizumab, an immunotherapy drug itself without chemotherapy, given to people whose cancers had high expression of a protein called PD-L1. And in that study, which was presented in 2016 in Europe by Martin Reck at Germany, what he showed was that if you start with immunotherapy, compared to chemotherapy, people live longer, better safety, better quality of life, and better survival. And this changed everything. And after that day, in October 2016, it was below the standard of care to give chemotherapy by itself for these patients. Immunotherapy was the wave of the future. That was 2016. We now have 5-year follow-up. And what we see at 5 years is a third of those patients on that study are alive today. Again, when they started this, the median survival was about a year. We have 1 in 3 still alive today, 5 years later. And all these patients stopped treatment after 2 years. That means 3 years with no therapy and no cancer. And what we like is the shape of this curve because it seems to flatten out at the end. And the tail of this curve suggests that for some people, that cancer won't come back. Just think about that for a moment. These cancers will not come back. So these studies were hugely important. This was not an incremental improvement in survival. This was not chemotherapy A was a little better than chemotherapy B. This is what we should use now. This changed more than our treatment algorithms. This changed our expectations. This changed what we were capable of. This opened the door to possibilities that we had never considered. That someone diagnosed with a stage 4 lung cancer could be cured of their cancer. And yes, we can say that now, that some people are cured of their lung cancer. It did more than raise the ceiling. It blew the roof off. And so this is now what we expect. But this is a bite of the apple, because now this is what we want for everybody. So how do we get there? For patients that don't have an actionable driver, immunotherapy is our standard of care. Everyone gets immunotherapy, and we have lots of ways to deliver it and more to come. This is an exciting area of disease. Okay, this is a sandwich. All right, specifically, this is a steak sandwich from Permane Brothers in Pittsburgh, which is where I'm from, all right? Okay. But this is also how we in medicine are taught to give feedback, how we are taught to summarize the state of things. That you start with positives. We made a lot of progress in lung cancer. That's worth celebrating. We can pat ourselves in the back a little bit. It's hard-earned. And we end with a positive because we're excited about the future and what's coming next. We have a lot of enthusiasm about what's happening. But in the middle, we want to talk about some things where we could do better, where we could see some improvement, because it's not all cheery. And while we're excited about the progress we've made and serious survival gains, the truth is our survival is still very poor. A 21% improvement is great, but an absolute 5-year survival of 23% is terrible. Compare that to the high 90s for breast cancer, prostate cancer. We're happy about the advances. We have a long way to go. And as was mentioned, lung cancer is the most lethal cancer for men and women in the US by far, more than breast cancer, prostate cancer, colon cancer combined. Right? And yet it doesn't really get all the attention that it should. We have amazing targeted drugs. The science that goes into these, the rapid trials, all the money invested in this, we have amazing drugs, but we're not testing patients to see if they're candidates for them. If we think of EGFR, we have effective drugs that improve for more than a decade. 1 in 4 patients in the US with no access problems already involved in US oncology, that's where this data is from. Access to testing, eliminate all barriers. 1 in 4 is not getting tested. Inexcusable. What's even more inexcusable, even more shameful, is that our testing rates are not equitable, and there are significant disparities in access. Here we can assume access available to everyone. We don't do a good job testing. In the real world, where access is not guaranteed for everyone, we do a much worse job. This is almost a greater tragedy than not having the drugs at all. 5-year survival rate, 33%, very good. Much, much better than it was before. It still means 2/3 of patients, though, not alive at 2 years. And we need to elevate that tail. We need to get that kind of response for everyone. A lofty goal, but those are the only ones that are worthwhile. Remarkable progress, but it could be so much more if we would apply testing to everyone. Yep. Some people get tested, we see those results, they never get acted upon. We see patients diagnosed with an EGFR mutant or ALK-positive lung cancer where we know we have effective drugs, and for some reason they never get them. Right? A tragedy. The wrong treatment instead given, or given in the wrong order. What we need is education, because remember, most oncologists in the US completed their training before we knew any of this. And so it's a big ask, not just to learn new drugs, but to learn new paradigms, learn new tests, learn new molecular diagnostics. We need to educate our patients, we need to educate our advocates and our politicians. We need access to the tests, to the drugs, to the doctors, to the specialists, and we need funding. We have made tremendous progress. Right? And I'm biased, but I think more progress than maybe any other cancer that's out there on relatively few funds. Right? This is from GO2, and we can see that lung cancer, despite it being the leading cause of cancer-related death, by far the least amount of federal funding per death. $19,000 for breast cancer, $8,000 for prostate, $3,000 for lung. We still make significant progress. Imagine what we could do. But we are excited about the future. Early detection is changing lung cancer, and we're going to see these numbers change dramatically over the next decade. Low-dose screening, CT scan, we know reduces lung cancer mortality, saves lives. And while not everyone who's eligible is getting a CT scan, I see the benefits of this every day in my clinic with early detected cancers with patients that are much better off because they had these screening CT scans. We see ongoing work looking at CT screening in non-smokers. As was mentioned, many of our patients had never smoked, still developing cancers. And again, if we find these cancers earlier, we can do so much more. And so exciting studies going on right now with CT screening in non-smokers with pretty remarkable findings. Blood-based detection, blood-based screening. It's not that far away. And really understanding why does lung cancer happen in people that haven't smoked. Because if we can understand how it happens, maybe we can prevent it from happening. We want to identify cancer at a stage where we have more options, including local therapy, and really understand the risk of lung cancer over time. And this is a space we're seeing tremendous work in the perioperative space. When we identify cancers earlier, we have so many more options. And I'm not just talking about surgery or radiation. We're now using immunotherapy in people with early stage lung cancer. And what we're seeing is if we give, in this case, 3 doses of immunotherapy before surgery, when we go to surgery and take that tumor out, 1 in 4 have no cancer left. All fibrotic scar, all inflammatory tissue, no remaining cancer. And we really think that those patients are cured. And this is where we're going to make a bigger impact. Detect the cancers earlier, improve our treatments for early stage cancers, and then prevent someone from ever getting advanced disease. That's what we want. We do want better treatment for late stage, but we'd love to prevent people from ever getting to late stage. And we can do that. Drug development has changed. We understand now we have to look at acquired resistance, develop new drugs to then prevent resistance. Our heroes are our medicinal chemists that sit in the laboratory and develop new molecules that do exactly what we want them to do. And it allows us in early stage trials and first in human studies to have this confidence that this drug will work, because this is the field now, this is chemistry. To understand the differences between all of us in the room, our own immune systems, how the things we eat, the things we drink, the things we're exposed to change our body, and how that changes the cancer and our response to that cancer. We have biomarkers that can not just predict how likely treatments are to work, but how we can surveil cancers over time. Cellular therapies, adoptive T-cell changes, and antibody drug conjugates. A great example of rational engineered molecules that help deliver drugs exactly where we need them to go. We're getting smarter with the medicines that we have. The field is moving at breakneck speed. So remarkable progress in diagnostics and therapeutics for lung cancer. We have better treatment, we have safer treatment, better responses, more importantly, higher expectations, really looking for long-term benefit. These incremental improvements, these 5% gains are not going to cut it anymore. We're not interested in that. Our goals are higher. The bar has been raised, and more we're meeting that bar. There are a lot of reasons for enthusiasm: early detection, early treatment, early access, remarkable progress, and imagine what we could do if we had a little more funding. With that, I'm at time. We're going to stop here. Thanks again, everybody.
So I'll be brave if you're brave. I'll be brave, but only if you're